Hello friends, I am Dr. Rajesh Chokhani, a general pediatrician from Bandra, Mumbai, and today we will be talking about the role of ECG and 2D echo. So as we all know, an ECG can provide us a host of information, but typically in adults it is used to study ischemic heart disease, and in both adults and children it is used to study rate and rhythm abnormalities commonly, and then uncommonly various indications. So, in an adult with a compatible history, ECG can strongly suggest myocardial ischemia or infarction through the changes like ST elevation, Q wave, ST depression, T wave inversion, etc. But it is important to understand that these changes evolve over time, and therefore at one point it may not be diagnostic. Similarly, every individual change may have other reasons also behind them. So, the diagnosis of myocardial ischemia or infarction in an adult is always a composite of clinical symptoms, biochemical markers, and these ECG changes. Of course, at the other end of the spectrum, a single normal isolated ECG does not necessarily rule out a cardiac abnormality if the ECG has not been done at the right time. Now, if we have a patient with a fast pulse rate, suspecting sinus tachycardia is very easy usually from the history, and the treatment is only treating the underlying cause. But an ECG can help us to diagnose supraventricular tachycardia, which may need specific treatment. So in SVT, the ECG will show us either absent or abnormal P waves, narrow QRS complexes without any beat-to-beat variability at a very fast rate. So the rate is not clinically countable in SVT, and the ECG will show that the rate is more than 220 per minute in an infant or more than 180 per minute in a child. So this helps us pick up a supraventricular tachycardia, this kind of a pattern. As against this, a wide complex QRS is seen in ventricular origin of the beat, so it represents ventricular tachycardia. This again needs to be treated very urgently because it has the potential to progress into ventricular fibrillation, which can be life-threatening. Now, if you have a patient with bradycardia, the commonest clinical cause of bradycardia is hypoxia, and these patients are acutely sick. But in patients who are bradycardic but not acutely sick, they may or may not have symptoms, and we may pick up a complete heart block in such patients on an ECG. How does this ECG look like? There are isolated P waves and isolated QRS complexes which are not related to each other, so they are independent of each other. The rate of P waves is usually the normal rate. The rate of QRS complexes is usually half the rate of the P waves. When we see this pattern in a newborn, it suggests often is due to maternal SLE. Now coming to an irregular pulse clinically, an ECG will commonly help us to pick up one of three abnormalities, though uncommonly or rarely it can pick up various other abnormalities. So the first common abnormality is a single random wide-based QRS complex which is abnormal looking, which is a ventricular ectopic beat, which is very common in children. The second abnormality which we pick up is in adults, which is atrial fibrillation, which is again fairly common, where we will not have any definite P waves, but instead there will be a very wavy fibrillatory line which is coarse and which is interspersed by irregular QRS complexes. So this is the atrial fibrillation pattern. And the third pattern on an ECG in an irregular pulse is various kinds of heart blocks. So we may see progressive prolongation of the PR interval to a point where that beat is not conducted to the ventricles, and therefore there is only a P wave without a following QRS complex, or there would be a fixed ratio of normal P wave QRS complexes to a isolated P wave, which is the beat which failed to conduct. So there could be a fixed ratio of this. So these are the various kinds of blocks that we may see on a ECG in a patient with a irregular pulse. Now, in a patient with suspected cardiogenic syncope, it is mandatory to obtain an ECG, and it may pick up arrhythmogenic abnormalities like long QT interval or even short QT interval, pre-excitation syndromes like WPW syndrome, or various kinds of heart blocks. At times, a 24-hour Holter monitoring is required to pick up abnormalities which are intermittent. A prolonged PR interval on ECG is a minor criterion to pick up acute rheumatic fever, and this kind of a prolonged PR interval is also a non-specific sign of many other forms of myocarditis, maybe with other non-specific ECG changes. In a patient who's pulseless and unresponsive, it is the ECG tracing on a monitor which helps us to differentiate between shockable rhythms, that are ventricular tachycardia, which is pulseless, or ventricular fibrillation, which we need synchronized cardioversion or defibrillation, and non-shockable rhythms, that is asystole or pulseless electrical activity, where asystole needs CPR and epinephrine, and PEA needs CPR and correction of underlying abnormalities. Now, electrolyte abnormalities like hypokalemia and hyperkalemia also are picked up on an ECG through flat T waves or peaked T waves respectively, and these provide us supportive evidence that the hypokalemia is kind of impacting at the cellular level. Similarly, hypocalcemia may be seen in the form of a prolonged QT interval. The ECG sometimes performed routinely in an adult may pick up a LVH pattern and may alert us to the presence of hypertension which the patient was totally unaware of, systemic hypertension. Congenital heart diseases are actually confirmed by a 2D echo, but again we can get supportive evidence on an ECG in the form of RS-RDS pattern in ASD or chamber hypertrophy in other congenital heart diseases. So now coming to a 2D echo. A 2D echo is routinely used to confirm the presence of congenital heart disease. It tells us the actual structural abnormality, but it also tells us many things about the flow of blood, the pressure gradients, the presence and degree of pulmonary hypertension, and therefore gives us deeper insights into the operative feasibility, etc. Similarly, a 2D echo helps to pick up and confirm both congenital and acquired structural valvular heart disease. Here again, it gives us even abnormalities in the endocardium so that we can pick up verrucae and vegetations and therefore confirm a rheumatic etiology of some of these valvular heart diseases and even pick up bacterial endocarditis in a patient with fever. Similarly, the 2D echo can also pick up myocardial abnormalities, so myocardial dysfunction in myocarditis or a cardiomyopathy, and even pericardial abnormalities like a pericardial effusion. In fact, it can tell us about myocardial contractility, end diastolic ventricular volumes, and ventricular ejection fractions, and all these are parameters of ventricular function so that we can study both left ventricular and right ventricular function. More commonly in adults, it can also tell us about regional wall motion abnormalities which help us to diagnose and then follow up an acute coronary syndrome. A 2D echo is also used to pick up coronary artery abnormalities and therefore diagnose and then follow up a Kawasaki syndrome. And it's a very important investigation in all patients who have some implanted devices. So all this kind of information which we get from a 2D echo helps us even in therapeutic decision making, both in congenital heart disease and even in adults with ischemic heart disease, as to what steps subsequently will help or what will not help. Now 2D echo, the advantage is that it is quite non-invasive, but a small disadvantage is that it is operator dependent and we need a good window, which is sometimes difficult in obese patients and patients with COPD. Now what is a 3D echo? A 3D echo is a reconstruction of 2D echo images which gives us a better volumetric assessment, and a transesophageal echocardiography gives us a better visualization of the posterior heart structures. So friends, to summarize, even in today's modern era, simple tests like a chest X-ray and a ECG are very important in suspected cardiac disease, because things like airway and lungs are not seen on a 2D echo, an advanced investigation. And even rhythm abnormalities need an ECG rather than a 2D echo to pick them up. So these tests are important. So even we should be aware of how we should use a ECG and a 2D echo in our day-to-day practice. Thank you. The next video will be by Khare sir on role of EEG